Conditions that aren't what they seem. Tumors about the foot and knee. I'm Mary Lloyd, Ireland, and I'm going to share with you some cases that I've taken care of throughout my career. My practice is in Lexington, Kentucky at the University of Kentucky. 15-year-old basketball athlete started having left foot pain after no injury. When I first saw him, he'd been having pain for about 6 months. It was worse at night, but it did get better when he took Naprosyn. However, unfortunately, he developed a GI bleed, and the Naprosyn had to be discontinued, and his pain came back, particularly at night. He did walk with a limp, not wanting to put full weight on his left heel. He hadn't had any recent travel out of the country, no history of a rheumatologic process. His pain was over his heel. These were his initial x-rays. Upper left, the lateral view, you can see the apophysis is open. This is the normal sclerosis that occurs, the calcaneal apophysis that's pretty typical. Subtalar joint looked okay. Joints really looked okay. There was a suggestion of a radiopacity right here with central radiolucency. CT scan, this is his left calcaneus. You can see here where there is sclerosis. And on his bone scan, his epiphyseal plates were still wide open, but his bone scan did light up. Going back to this view that was hard to see, the trabecula of the calcaneus look okay, but if you look at this, there is suggestion of a lesion on plain films that is confirmed on the bone scan, but also the CT scan. So our differential with heel pain in an adolescent would be some type of a tumor, like an osteoid osteoma. Also, there can be rheumatologic condition such as Reiter syndrome, ankylosing spondylitis, maybe without spinal involvement, infection, Reiter syndrome. Think about uveitis associated with these inflammatory conditions. His diagnosis indeed was an osteoid osteoma. I localized this with CT scan since there wasn't any overlying way to tell exactly where the tumor was that was in the calcaneus itself. Superficial nerve here was probably being stretched a bit if there was a little bit of swelling. Secretion of prostaglandins occurs with this tumor, hence the Naprosyn made him a lot better, but unfortunately he couldn't continue to take it because of his GI bleed. The classic history for an osteoid osteoma: night pain, improvement with non-steroidal anti-inflammatory medicines. A Cloward drill was used to take this tumor out, and this has been called cherry caviar, so soft on the inside. This is the cortical bone. Didn't bone graft him, he ended up doing fine. This is what the classic osteoid osteoma looks like. And his excisional biopsy was successful, pain went away, and he was able to sleep. Consider a condition that is not what it seems if it's a bit unusual, persistent pain, night pain, or you just have a bad feeling, and those are the individuals that I would work up appropriately with advanced imaging after the plain films. This is a 16-year-old male who came in after being kneed by another player when he was playing basketball a month ago. No prior knee problems. If you look at this x-ray, this is very concerning. This permeative distal metaphyseal lesion with a Codman's triangle periosteal reaction. You can see it best on the AP view. Looks like here, this is here posteriorly, and then you can see this periosteal reaction here. His diagnosis was a right distal femoral osteosarcoma that was treated with an amputation. Critically look at all the x-rays that you get. If the mechanism of injury and the look on the parent's, family's, patient's face is a little concerning, then you should be concerned. Night pain is also a big concern. This is a 38-year-old printing company manager, former basketball athlete, had left knee pain, insidious onset of pain, did have pain at night. His diagnosis was a giant cell tumor. He had an excisional biopsy and cementation and has done well. Make the diagnosis. Look at this lucent lesion. Doesn't look quite like the osteosarcoma in that the body is trying to wall it off. There's a little bit of sclerosis here, but an expansile lesion. Closer up view of the lateral view, AP view. Another view of the lesion. Bone scan, significant increased uptake around the area of the giant cell tumor. MRI scan shows this again. It's not expansile or permeative, but locally aggressive. This is his 3-year follow-up, so there's no evidence of recurrent giant cell tumor, curettage, and this is the cement that was placed in there. Original and follow-up. I hope these cases will make you think about certain conditions that you may not have thought about before. Remember, you may not have seen it, but it has seen you.